Would surprise me. Only because.
Hi, everybody. Welcome.
But also the situation.
Welcome to Grand Rounds. We have Dr.
I mean, if I have no other.
Sorry about that. Welcome to Grand Rounds. We have Dr. Robert Trainer from the VA here to talk about chronic pain, addiction, and anxiety from the inside out.
All right, good morning, everyone. I know most everybody, but just as a self-introduction, I studied formerly in anesthesia and did a chronic pain fellowship in 2010 at Brigham and Beth Israel. Went into private practice for a little while, academia, and then military medicine again. I've been in the VA for almost 10 years, and my head said never again. But I got interested in this talk a lot with what I'm doing with the wound warriors in the transition project. We're doing stellate ganglion blocks for PTSD. Some of this sort of is, I feel like, necessary knowledge that I work with Dr. Robbins on. And also I got board certified in addiction medicine along the way because it was a grandfathered in type deal. And I've been teaching in that for law enforcement mostly. So there's a little piece of that. Hopefully there's a little something for everybody, and there's some value for your time early this morning. So we can understand a little bit about pain from addiction, anxiety. We always talk about how they coexist. And this talk, maybe if I had to summarize it, is a little bit of the why. And the why from a neuroanatomical point of view, the systems are probably best studied in the addiction model. It's maybe even the most clear. So we'll understand distinct locations of brain regions, but also the diffuse involvement that can inevitably occur. And then there's a bit on treatment efficacy and really cautionary tales in some ways. So chronic pain is a pervasive in our society today, about 20%. Interestingly, in China, they report about 30%. But it coexists with depression, high suicide risk, substance use and misuse. 20% chronic pain, almost 7% high impact chronic pain. And to truly understand why, you have to understand how someone may have a pre-existing comorbidities or predisposition to developing those. So in the NLP was created for utilitarianism, where they stated nature has placed mankind under the governance of two sovereign masters, pleasure or pain. Chronic pain is persistence of the memory of pain or the inability to extinguish the memory of pain evoked by an initial inciting event. And that's different than the IASP definition that the fellows will have to learn for their boards, but I like this because I think it's more true to what we see. What my old pain psychologist used to say, to sort of bridge the subject with his patients, if pain makes your anxiety worse, could your anxiety make your pain worse? And it's a way to say, people have been told pain is all in your head. Well, it is, no brain, no pain. But ultimately, you want to get to where you have a therapeutic relationship, and that sometimes can help. And also, every pain consult I get says patient's only crazy or drug seeking because of pain, so just fix the pain and they'll be fine. So everyone realizes they're linked, but for different reasons. So which of the following is necessary for survival? Pain? Yeah. So there's a family of who have a defect in one of the neuronal neuron-making substances, I should say. And so they have a loss of function mutation in this sodium channel, and they're insensitive to pain. So this is a operating room picture of a sword swallower, one of a family, one of the kids in the family who really thought he was making a few extra bucks on the streets and felt no pain, but yet was able to injure himself. When they found his brother, he was walking around with an open fracture because he had jumped off the roof a week before. So pain is probably good. Fear. There are certain dopamine receptors, the DRD4, involved in risk-taking A lot of the out of Africa studies that have been done really have seen this novelty-seeking gene, and it's probably more prevalent in Americans than other cultures because of what it took to live on the frontiers and natural selection for that. But fear is probably a good thing. It prevents things like this. They still make it so somebody must be eating. Cravings are also, I would argue, necessary. And that's why there's a hijacking of the inherent system in things like addiction. So that we'll talk a little bit about this. Reward prediction error exists in the brain to give salience to certain rewarding stimuli, back up the cues that got you there so you can remember where to find the berries. I'm kind of happy to see that Zelda has made a comeback because it's a game I can play with my kids that I used to be cool and is cool again. But it's that hunting gathering idea that keeps us playing video games and is inherent to us. But when pain turns to chronic pain, fear and anxiety and cravings to addiction, that's when they come to the healthcare system. And that's what we, these normal systems that we have become hijacked. And that's sort of the theme of this. Speaking about pain, there's a need for the objective biomarkers of pain. We've known that for a while. Really, the scale of 1 out of 10, you see the Lego face there. How many people say they have a pain score of 12, 15? And, harder to treat. But we're looking for biomarkers. I'll talk a little bit about some of the functional brain imaging, the neuroanatomy. Busy slide, I apologize, is probably the only one in here, but it's defining pain. It's a sensation perceived as painful by one person, but uncomfortable and not painful or even pleasurable to others. And within the same person, it can be modulated based on their threat value, the context which is presented. So it makes this science very, very difficult, as you can imagine. So we have a functional MRI, PET scan. I'll show you some of the Stanford studies where they have the best functional MRI probably in the world. There's a distributed network in the brain, a default mode network of sorts for almost everything. But you have a sensory discriminative aspect, a cognitive, emotional portion of pain. And people try to tease this out. But essentially, we understand the prefrontal cortex, the last to develop in all humans, usually by age 20, before you develop prefrontal cortex. It's what makes us human, the upper brain as opposed to the reptile brain. But you have all cortical pathways and descending inhibitory pathways. So that's the main dogma that's existed for the last 20 years. I'll show you a little bit of how people are trying to tease that out and fine tune it. But essentially, if you go back to that cortical descending inhibitory, and these are targets for even things like deep brain stimulation for pain. So, but you can imagine, so the descending pain modulatory pathways include the amygdala. We'll talk about that. It's pretty much, that's a fear center as well. So, right away you see that there's going to be this overlap. The periaqueductal gray is probably the board's probably the most, if you see descending inhibitory and see periaqueductal gray, that's probably the one you want to pick. RVM is the other one. There's off neurons. Those are the mu opiate receptors. There's on neurons because if something is actively mauling you, you would want to know and actually do something about it. So that's a little bit of what it looks like, this descending inhibitory and the cortical. You can see the cortical, a lot of it ends in ACC, anterior cingulate cortex. That's a big site for pain, and deep brain stimulation is usually centered there. Although it's not the most effective, I don't mean to suggest that. But bouncing off the amygdala, and then the nucleus accumbens is the pleasure center. So really that idea that pain is the absence of pleasure it really comes true when you look at some of the neuroanatomy. This is some work by DeRitter, and he's trying to tease out this medial or this ascending cortical pathway starting from the bottom up, suggesting that there's a suffering component, the medial pathway, and a painfulness component, the lateral pathway. Still maintaining the inhibitory pathways, that's pretty well solidified. But it's interesting work because there's people that are studying, devoting their whole careers to saying that their method of treatment will decrease the medial pathway and or the lateral. So just some of the work from Stanford, without going into all of it, there's a connectivity difficulty where this is patients that were catastrophizers. And so they had a stronger correlation or stronger fMRI signal on the central executive pathway than the default network. And the default network is a whole nother thing that I won't completely get into, but that's where you're autopilot. So when you're doing nothing, the brain is always on. So, but to what extent is it on, and to, you know, where's your emotional home? All these things are subjects of other therapies, but essentially the worst thing you can do is catastrophize and have your own brain work against you. And that's what they showed in some of these studies. They really found 47 unicorns here where they had no mood or thought personality disorders, radicular symptoms, or prescriptions of high dose analgesics. And they studied them to find a signature for low back pain specifically. And that is pretty rare. You can see it lighting up just to the smallest amount when they do a subtraction analysis. So there probably is some pure type pain for each part of the body based on the homunculus. But they had found a very difficult population to find. So it exists if you're interested. The Stanford group is doing great things with this. They had to figure out some of these people. They took rugby players, put them in a fMRI, and started banging on their shin. So I always kind of like that concept as former rugby player. But as it gets more complicated, you can see the prefrontal areas can be activated by placebo even, placebo effect being 30%. I don't discount it. We use it all the time. It's a great thing, but it's going to interfere with many of your interventions, and they even show it in brain imaging. But things like social exclusion can increase the activity in the pain centers. On the corollary, the bottom left, this was 17 patients where they showed a picture of their romantic partner, and they had protective effects on the descending inhibitory pathways. So, you know, it gets mixed with the human condition. Pain does for sure. Even anticipation will start lighting up these areas. Again, we talked about before that the context of when the pain came, was it fear associated with it? It'll bring it back. The pain will appear to magnify. And to the patients, it's real, but they're using some of the same centers for fear, addiction, and pain. So if we're looking at the default network, okay, so just, I think one of the Kennedys talked about this in the terms of addiction, and then they sort of were able to study the dopamine system in this context, but you might think it's cool. So the baseline brain is always on. You know, they say don't think of an elephant. Can't not think of an elephant. So you always have some activity in the brain. 3 to 5 spikes per second is about the rhythm of a normal functioning dopamine system in the nucleus accumbens. If you get hyperstimulation, your brain can do things to turn that down, especially if it's prolonged. And so you get 20 spikes per second. Now, the dopamine deficiency, the reward deficiency hypothesis, which is what we used for many years as to why people might continue to use a drug. They're saying that they don't feel normal even with nothing, so they take drugs to feel normal. That's what they're talking about. And so with persistent use, the lot of that up and the dopamine hits back hard. This can last years, where they have, instead of the 3 to 5, they have a 0. So speaking a bit about addiction, it is one of the leaders in budget and going up every year. This last year went up even by $363 million. They're increasing the funding and tying it to things like related research into opiates and pain management. So there's spin-offs from the HEAL initiative, and there's money out there for chronic pain folks, simple country pain doctors like us. But a lot of it goes to addiction treatments, addiction research. But the question is, if there is a lot of research done in treating addiction is applicable to chronic pain. And as I said before, pain, fear, and cravings are all good things. They're all in our brains for survival. You can already sort of tell yourself, though, yes, but if I have anxiety or chronic pain, these are negative states. Whereas the cravings for positive things like finding berries, hunting, gathering, these are things I would probably seek out. So in some ways, it's more pure that people are actively seeking they're not actually seeking pain or fear, but they are actively seeking the craving. So there's obvious differences, but nevertheless, the brain responds to hyperstimulation in similar ways. All right, that's a lot to say that. But it's not a brand new idea. There's chronic pain mechanisms, common brain mechanisms, chronic pain and addiction, alcohol dependence is a chronic pain disorder, the anatomy of pain and suffering in the brain. So a lot of these are, I chose some of these are 2012, 2016. This was starting the evolution of where people, they believed in this reward deficiency hypothesis. So people would, like you, it's hard for us to understand addiction, right? So they would understand it in a way that it's just like coffee. If I don't have coffee, I get a headache, so I have coffee. Well, an addict doesn't feel good because they're coming down, so they use again. And that is the negative reinforcement model, which we were stuck with for a long time until we realized that the drug itself can change the brain, hijack the normal system, just like pain and fear can. Switching gears a little bit, so NIDA is where a lot of this, so NIDA is where that $1.5 billion goes, and Dr. Volkow oversees it. Some of the research they've done early on really shows a global energy defect in, and this lasts in her estimate in her studies pretty good, about 6 months. So for about 6 months, someone with a substance use disorder, they use cocaine here, they use opiates also. About 6 months, the brain is not going to work quite right. People are going to say they're sluggish. People are going to say they don't feel right. And that's the global decrease in metabolism. So they have a slower brain. So what does all this mean? How are all these pictures related? So the reward prediction error is something that's built into our system, and it's how we built AI, as a matter of fact. So in the first one, on the green slide, you see the dopamine system going along, 3 to 5 spikes. A reward happens out of nowhere. Well, that was pretty cool. So let's find out how we got there. So now the brain is looking for cues, trying to back up. How did I find the berries? This guy's holding berries. So your brain wants to remember take a left here, take a right there, back up exactly how to get those, and those will become what we call cues. So things that were salient before are now important. The street corner where you used to buy drugs didn't matter before, now you pass it and it's a trigger. Some addicts had said the bleach in the grocery store will trigger them when they walk down the aisle. But nevertheless, so now the cue happens, the reward happens. Oh, this makes sense. Everything's great. Now the cue happens, no reward, and there's a problem. That's the reward deficiency. Now your brain, you're working against 1 million neurons that are trying to get you to use that, to get that reward that you missed. So the backgammon picture is the first AI, actually. So they programmers at IBM, they just taught the computer the rules of the game, nothing else, and let it play. And every time it won, it would remember how it won. And so little by little it would go on, and it became unbeatable because it would remember every possible way to win. And so now the newer systems are using some of that plus other things that are at the Elon Musk level. I won't discuss here. So when we say neural hijacking or positive reinforcement, what does it mean? So our basic drive, if you say food and sex, 1.5, 2.0 times your normal dopamine level. And these are, meant to help keep you survive and procreate. The effect of drugs on dopamine, on the other hand, are super physiologic and prolonged many times. You can see things like cocaine and morphine will bump up and stay up. And that keeps barraging the system, hitting the system, where the system has to turn itself down. The amphetamines are interesting because you see the Breaking Bad stories and all the rest. People are going around without teeth and just disheveled after one hit a week ago, and it's something they will chase for years. This amphetamine high. So none of us could really ever understand 1,000 when the highest you're normally going to be exposed to is a 200 level. So it is something where hitting the system hard really shuts it down, and really they're looking for this reward again and again and again. So of course, video game industry was very interested in addiction. So the 15, 25, 1,000 rule is if you're playing a video game and you go 15 times without winning, you'll give up and never play again. If, on the other hand, you win 25% of the time, you keep playing. About 1 in 1,000 should be a big reward. It shouldn't be too easy. So I go, my son is turning on Angry Birds, and they ask how old he is, to see if they can trick him. You can already see their business model. Keep playing, keep buying. I have fallen into this trap many times. But here we are, right? 1-4. So he's going to win something. He's probably going to keep playing. And it's a halfway decent prize. 1 in 5 here, 20%, even more likely to play. And then you can see the treasures, legendary, you need 900. So close to 1 in 1,000, close to 1 in 25%. So they've used this pretty well. Similarly, the gaming industry has decided or realized that finding and killing a food source is a human built into the human nervous system. So a first-person shooter game should be very interesting, and it is. So people play this and they get that dopamine surge from a system that's normal, but now it's at a super physiologic level. The dopamine reward loop, we're seeing a lot with cell phones and young kids, where they keep feeding that and don't even realize they can't live without a phone. So it relates to food as well. So food and opiates are in the core of the nucleus accumbens. That's where the upregulation occurs. Yale actually has a scale of the most addictive and the least addictive foods. So have all the cucumbers you want. Pizza is the most addictive. The internet is, of course, full with porn. The ability, the drive to procreate is normal, but you'll see we'll talk about numbing pleasure centers, cravings, and compulsive behavior. So anybody, why is there only one type of ketchup and there's 50 mustards? Why is ketchup addictive? Why do kids love ketchup?
Sweet. Sugar. 1/4 of pizza.
Yeah, it goes with everything, right? So it's sweet, but it's also sour, bitter, salty, and umami. So it has everything. Nothing you'd ever find in nature. It hits every taste receptor. And so no need to create more ketchups because it's everything
All in one.
all in one. Yeah, food group. Right?
Yeah.
All right, so this is there's basically 4 brain areas, no quiz at the end, but essentially we talked about how the addiction center, addiction research has really teased out these pathways to a greater degree, perhaps than others. And essentially, you have drugs now like fentanyl, which can act as guided missiles to the nucleus accumbens, and really people will ruin their whole lives trying these drugs once or twice. And so that always interested me, coming from anesthesia, where people got residents, families got addicted to fentanyl on the job and just threw away their whole lives. So it will strengthen cues, numb the pleasure center, and decrease inhibitions. And I'll show you just a little bit about, this is the idea that, again, it's not like coffee. It's not, you're not just taking an opiate because you have a hangover. It's the opiates have actually changed the brain. And so strengthening cues comes from the ventral tegmental area, releases dopamine upon an unexpected reward. That's the reward deficiency. And then it can help an animal find how to find the berries again. Dopamine strengthens the steps taken to get to that reward. And it's associated with craving, not the pleasure. So that's important because people will tell you that I don't even get pleasure from drugs. I just use, and I don't even know why. No, that's ventral tegmental area. They're very associated with smoking, by the way. So that's where all the Chantix works and things like that. Numbing the pleasure center is where that overstimulation we talked about, living in a world of overstimulation now, we talked about in behavioral things, but it's specific to drugs where it's been studied the best, overstimulating the nucleus accumbens. It's so much overstimulation it will release CREB, we call the production of dynorphin, to turn down the signal. So from 20, it wants to turn down to 10. Unfortunately, in doing so, it turns down your normal 3 to 0. You need more to get high, some to feel normal. And the 4 is the most involved in alcohol, overeating. Prefrontal cortex instead is the last to develop. This is where a lot of your decision making comes in. The prefrontal cortex is really just a thin layer that goes over the cortex. And so it's a diffuse layer. It's not like you can just point to that one spot, although that's exactly what this arrow is doing. It's a little misleading. It's a thin layer throughout, and it's developed to different degrees in many people. But it definitely develops in the preteen years. The teenagers who have to think about other people's feelings cannot do so because that's also where this comes from. But the prefrontal cortex can become hypoactive in this battle, where the nucleus accumbens will take charge. It's a deep brain structure. It's been there longer. It's the reptile brain, 2 million years old. So the other thing is that you'll hear about, maybe less well studied because it's also diffuse structure, and it's what we didn't. When I was in med school, there were only 4 lobes of the brain. This is now the 5th, the insula. And it has direct connections with all these cortical areas that we talked about. It's involved in pain perception, speech, smell, taste, social, emotion processing. And then this concept of what's called interoception. So knowing what's going on in your own body. And it's sort of a meeting point where you take outside senses and inside. And so you really, it's really a check on your internal system. But patients with lesions here can have a disruption in addiction to cigarette smoking. There's insular strokes that are rare, but have been studied in the at least 20 cases in the Mayo Clinic, where they saw just this decrease in something that's, cigarette smoking is 1 out of 10, it's the same as heroin. So it takes 10 attempts usually to cure that addiction. And here, you just need 1 insular stroke. But people will become more aware of their body feelings due to greater interoception. And so that can, as you can imagine, be off-putting to some people. So that'll instill a fear in them. Say, my heart's beating, I can feel it racing. For others, it can be protective against things like addiction because a normal reward, this cup of coffee tastes great, I really enjoy it. That can be protective against, drug-seeking behavior. But it's activated during pain, so that's a normal target. It's also been targeted, we could see, with opiates, cannabinoids, and ketamine, all of which have been used for depression, anxiety, pain, and addiction. So just kind of by accident, we've seen that these areas, or this area, the drugs we're using are targeting these syndromes. And for a while, we didn't know that. That's where they worked. And so it has even more implications now that studying MRI images of almost 8,000 brains. They saw it's a seat of many psychological disorders, including anxiety, depression, addiction, OCD. And there's less gray matter in 3 areas in all these brains: the left and right anterior insula and the dorsal anterior cingulate. So again, a target that wasn't discussed before is becoming, in the last decade, becoming much more in the forefront of a target and somewhere to look. Switching gears back to our model, some of the pain. So how can we use some of this information we've gained with the billions and billions of dollars of addiction research with the help of video game producers? Now we look a little bit at pain and see if some of those things hold true. There's about 7 mechanisms of chronic pain. There's a whole talk in itself, but essentially peripheral sensitization is what you see on the other slide. High stimulus, and then next time you hit that area, it takes off, and you have that phenomenon called wind up or peripheral sensitization. And there's a wind up in the central and a peripheral. Phenotype switching has been one of the more interesting to me. I did some research on this area where you can have normal A beta fibers, which are responsible for light touch. They can fiber type switch to C fibers. And so that's when you meet someone with allodynia. That's the mechanism of allodynia. So what used to be light touch now hurts. And so that's classic for allodynia, chronic pain, central sensitization, and a very, very difficult place to treat. You have the nerves themselves, especially the dorsal root ganglia, become excitable. There's structural reorganization both at the brain and the spinal cord, and then decreased inhibition where you actually have apoptosis of some of the protective areas that turn down the signal. So a lot of them are peripheral, as you can imagine. So there are some central changes that will occur with extreme states of pain where pain just doesn't go away, almost like the organism gives up. But, again, pain and fear are not consciously desired, so that you're going to work against this central sensitization as much as you can. And we're going to try to help patients with bridging with gabapentin, Lyrica, Lamictal, all the things to try to decrease this onset of central sensitization. And the idea of treating acute pain before it becomes chronic pain is also highly embedded in this. So, that's sort of the mechanism a lot on that slide, and again with the talking itself. But if we talk about sort of a pain drug, with the opiates class, it comes from opium, which is the latex secreted from the opium poppy. There was the opium wars where 25% of the male population of China was addicted in the 1800s. And it was believed that injecting was less addictive and more fashionable than smoking. So the opium wars, the Chinese were not the only ones who got addicted. There's many during the Civil War who were dispensed morphine in syringes. Then along came Bayer, maker of aspirin. They developed heroin because it was, they said 2 times stronger, it's 10 times stronger. And they said you can use this as a cough suppressant because morphine's addictive. And so this is the cure. And for over 10 years, they sold that. The junkies, that term you hear, is from Vietnam era veterans who actually sold scrap metal to support their habit. But if you ever are asked by a patient what's going to happen if I stop these drugs, I've heard I should stop them, I want to stop them. It's basically the opposite of whatever the high is. And that goes for just about any addiction. So they're constipated, now they have diarrhea. Some patients have come tell me that I'm having 2 bowel movements a day. It's crazy. That's normal. They become more anxious because the drugs themselves can be very, most people feel at ease and peaceful on opium. Warm, you'll see that they have these chills, and it's painful. The system that you decreased now has come back. So the theme of everything in Australia will kill you. This is the Taipei snake. One bite will literally kill 1,000 people, and it's because it'll bind to the acetylcholine receptor. It will never let go until enough time goes by. So if you're on a ventilator long enough, that's the only way to survive. Essentially, some of the drugs we have bind these receptors so hard that getting them off takes days, weeks. And one of them is buprenorphine, Suboxone, we know it as. It's the good part is it's partial agonist. So in pain management, I just wanted to introduce this to you because it's becoming more of a drug that we're using. It's approved for chronic pain in the patch form and the sublingual form. And probably more coming on that. But whereas methadone is a full agonist, people have been in methadone clinics, they have to get in line, they wait years before they can take home their supply, and it's all this monitoring. It's hard to even have a job. Buprenorphine in the 2000 Data Act is allowed to be prescribed for chronic pain and addiction secondarily. And a lot of legislation went into that. But essentially, it's becoming more popular now among chronic pain physicians, and you get a partial agonist effect. It binds 100 times stronger than even heroin. So it is a good drug to prevent people from using heroin or even dying if they did use heroin. Now, I always have to say this, that fentanyl changes the game, because fentanyl, enough of it will outcompete buprenorphine. So you can't just say, we'll put you on this, and if you make a mistake and use heroin, you won't die. That's depends which heroin and which dealer you got it from. But it has in this idea of opiate-induced hyperalgesia that you guys have heard of, using high-dose full agonist therapies is really implicated in that, whereas buprenorphine is not. And part of it is because it's more of an anti-hyperalgesic than it is an analgesic. So it's not a full agonist, which people have, patients might say it's not good enough, but in a sense, it prevents that opiate-induced hyperalgesia. It is safer to use. The overdose risk is much, much less. And so less tachyphylaxis, less addiction. And if you're going to come off of it in 2 years, most people would much rather come off of buprenorphine than they would come off methadone, which can take a decade in itself. So the opiate effects, what are they? So like cannabinoids, scientists found opiate receptors before we found endogenous opiate. There's 3 different ones, mu, gamma, and kappa, endorphins, enkephalins, endorphins, endomorphin, dynorphin, respectively. Opiates will stop pain at spinal cord lamina 2 to close the gate, and in the descending pathway in the periaqueduct of Gray, always a question. Boards. Narcan will block the placebo effect, also the acupuncture effect, preference to spicy foods, and the runner's high. So those are all probably endogenous. They are endogenous opiate effects. But how is it a drug of abuse? Back to the main part of this talk. So you can overstimulate the nucleus accumbens, large dopamine release, big reward. And now the reward prediction error backs up the cues. Opiates actually disinhibit the ventral tegmental area like alcohol, so they cause the urge directly. If the spike in the continual use is high enough, long enough, people are misusing opiates especially. The nucleus accumbens signal will be much, much greater than the prefrontal cortex, and then it'll win the battle, and you get hypoactivity in the prefrontal cortex. And the insula we talked about shows its blunted activity, and so the ability to process interoceptive information, which might be useful to say, what am I doing? Why am I doing this? And normal activities becoming less and less pleasurable because you're less able to process how pleasurable they might be. We're doing on time. All right. Well, time for questions. So essentially, just a few, I talked about a lot. What's the theme? I wondered that myself. So really, I guess, we want to understand as physicians why pain, fear, and addiction are co-localized, how people with pain might be at risk for becoming addicted to opiates. So we now screen for all these. We have better monitoring systems, a little bit of a stick with the carrot that wasn't there before. But essentially, understanding where someone's coming from. If they have anxiety and pain, is an opiate the best thing? Most of the screening tools, I'll just give you the synopsis, they say not to. A family history of abuse, ongoing untreated anxiety issues means they're probably going to use this drug for euphoria, to feel normal, and more likely to misuse it. So the global-based pain strategies on the horizon, really the CBT is obviously been around for a while. There's new iterations of it. I don't know how many people have heard of the marshmallow test. So they did it on 6-year-olds. They left them in a room. They said, here's a marshmallow, and if you don't eat it, and when I come back, I'll give you 2. And this was supposed to predict whether they did well on their SATs, maintained a good body in BMI index, and went on to become CEOs. And it had some validity to it, but it is a little bit of children that were implementing CBT early. So talk about that. So fear conditioning, try to distinguish the fear pathway, essentially introduce the fear and then guide people away from it. The kids that beat the marshmallow test, what did they do to beat it? Well, they hid the marshmallow, so they distracted them. They thought of cool things to impair the prefrontal cortex. I played with imaginary toys because it's distractionary. So all kind of early CBT when you think about it. But it can help people avoid the triggers. I talked about the guy walking through the grocery store. He smells bleach. And that was someone who had actively understood CBT and realized the cue and then just avoided it. So some of it is just awareness, teaching awareness. So CBT has actually shown increase in prefrontal gray matter. And this is an older study, but the newer ones are even showing meditation doing the same thing. So, we talked about decreasing gray matter in certain key areas that may be protective against chronic pain, addiction, anxiety. And so building that gray matter is protective. So this is a group called HeartMath. Has anybody heard of that? What's that?
HRV.
Yeah, they're doing a lot of heart rate variability studies. Dr. Robbins is using this over in Building 527 with the vets. And so essentially this group if they would be remiss to say that it's accelerated biofeedback, because they were actually selected for the Nobel Prize for some of the work. And the work was this intrinsic nervous system of the heart, where they found and have actually X-ray crystallography pictures of 40,000 up to 40,000 neurons from the heart that go to the brain, more so than from the brain going to the heart. And so they focus a lot on heart-based therapy. HeartMath is an idea of incorporating emotions, and really in a lot of ways they're working on insula interoception. And with a potential for down pathway, upregulating the down pathway, the perioccipital gray, but also sort of the meaning of pain, the human condition of how it is. And the Oppenheimer et al. Is, if you look at some of his work, that's where you'll see a lot of this deep science to it. But essentially targeting impulsivity, interoception, focus, control, and urge. And so here, in a sense, they have this monitoring system you can use. There's one for the earlobe, one for the hand, so patients can have a session of HeartMath and go through the techniques that they've developed, 4 or 5 of them. And you can see in the top one, that's the EEG and the EKG. So they're just looking at the heart and brain. And when they can teach them some of these coping skills, they'll see a coherence mechanism, and showing how the brain, the synchronicity of this will help the brain work to a greater extent, and to give these people the greater coping skills that are hard for them to come by. So conclusions: the brain has existing circuitry that allows pain to convey information to not just about localization, but the context and meaning, the higher centers. And that is where the emotional or medial pathway we talked about comes from. The creation of a chronic pain state requires alterations of key brain structures, and addiction research may be translatable to understanding pain. The areas of the brain involved in addiction, anxiety, and pain, both protective, prefrontal cortex, and the generative, amygdala and insula, are inseparable. Treating anyone with chronic pain necessitates co-treating anxiety, addiction, and depression because of the co-localization. And I would say even maybe pre-treating, especially if you're thinking that opiates may be appropriate for this person. Opiates, which were a mainstay, really require special consideration in this. Therapies in the future are, and all the above, are going to look at more and more pre and post brain scans and active ongoing brain scans, just like the HeartMath group is trying to look at this without an invasive method. There are plenty of places that are looking at brain structures. So this is time for questions. This is what I feel like I do every day. I try to change something at the VA. Turn it around. Time. I think we have 10 minutes if anyone has questions. Is there a chat function?
I have a question.
Yeah.
Have you seen anybody doing like psychological screening prior to starting like chronic opiates, so see if the patient's high risk use or anything like that.
Yeah, we do. We do the ORT, which is a 10.6 question scan, and the COM, which is a 2-page 25 question. And the score on those will predict whether they're low or it doesn't tell you whether to prescribe or not, but it'll say if they're low, medium, or high risk. And they're a lot of the agencies now are saying that you might inherit one of these patients and you're a chronic pain physician. Well, should you not take them because they're high risk and let them be in the community and maybe be mistreated, or should you take them, know they're high risk, and then do the extra monitoring? And that's what we usually do in the outside clinic I work in. Is we take them on, but say, listen, you're going to be subjected to more pill counts. If your urine's dirty, next week you're coming back, it's accelerated monitoring, and you get one chance. And we encourage use of buprenorphine actually.
Been reading a lot about low dose naltrexone. Coming to mind as like pain aid
Yeah.
versus buprenorphine.
No pharmaceutical company supporting that one. But yeah, it does have some benefit. In the acute pain setting, we used to run this as an infusion and even into the PACU for people with high tolerances. We know they're going to come out, they're superhuman already because of what they're on, but now they're having surgery. So you do see an acute benefit as far as sort of maintaining people on that. It's not approved for pain. You do have a 50 milligram dose for addiction, so people can take this on a daily as a pill. There's an injection that lasts a month, and there's even one now that lasts 3 months for Suboxone. So you know the concept is there to keep that baseline and to keep the what's believed to be this opiate-induced hyperalgesia. That's what it's believed to be treating.
It's like it's an antagonist, but also a weak partial agonist. So there are some studies coming out that are suggesting that a low dose can help with chronic pain. Let's see how it goes.
Right. So yeah, I mean, I briefly went over the different receptors.
Right.
So there's actually a mu1 and there's a mu2. The great search is on for a mu2, which does not cause respiratory depression and constipation, etc. So, but also some of these other drugs work on the kappa receptor, which is protective, and that's naltrexone, Suboxone are two of those. Yeah.
Talking about like addiction and dopamine and that whole pathway, and kind of chronic use of drugs. What about with things like prescription drugs like bupropion, which is a norepinephrine, selective norepinephrine and dopamine reuptake inhibitor? And what is that doing to the brain over time?
Yeah, so it's a good question. If we talk about drugs that can really induce that 1,000 mark or the 300 and hold, it's not really one of those. And even tramadol seemed to be less addictive because it's such a dirty drug. It has 5-HT, norepinephrine, weak opiate, bupropion also all over, and it works in different parts of the brain. So it's not that guided missile towards the nucleus accumbens, which is going to cause the surge, which is going to downregulate, which is going to make you build the cues. It doesn't do that. So you can get addicted to anything, but that many times is more of a psychological addiction and doesn't have the same changes to the brain that drug abuse would have.
Okay. I guess I wasn't thinking about it as an addictive agent, but as far as just like changing the regulation of the system over time, when you're showing the pre and post of like cocaine addiction and what it does globally to the brain, I was thinking about, what SSRIs and, various things might be doing over time chronically when you take it every single day for 20 years or whatever.
Yeah. So, I mean, that's your question is about the soup, right?
Yeah.
So all the drugs, if you look at it, we give, they're really moving chemicals around and there isn't anything adding. So this is a complaint that patients are having. I used to get this thing that gave me extra and now I'm just trying to be normal, whatever that is. But moving the chemicals around will have untold consequences, but to study something like that is quite a challenge. And it just isn't as pure as some of these other. That's why the addiction model is probably so well studied, because we've been our street drug addicts have been case studies, because some of these drugs are so profound and work so well at these overstimulating these targets that it really showed up on, lights up MRIs, and downright you see gray matter decreasing. It's not subtle in a lot of these patients. So you saw that picture where the whole brain metabolism is decreased. I mean, it's a shock. So the dopamine system can hit back hard. No chat. No chat GPT. Okay. All right. 4 minutes for coffee. Thanks, guys. Thanks for inviting me to Sheltering Arms. What do y'all do next? Oh.
Yeah. Thanks for coming.
Yeah, man.
I wonder.
I know, yeah.